Good day to all. This is Professor Osorio, and I truly hope that you are having a great day. Medical decision making at the end of life is crucial as it ensures that patients' values, preferences, and dignity are respected, guiding care that aligns with their wishes during one of the most vulnerable times in their lives. We will talk about our role as nurses in helping patients for their end of life care. The stories of the three individuals in this slide influenced many of the policies we now have in place. We will talk about them later in the presentation. Here is a YouTube video of a team of Macmillan palliative care nurses from Royal Stroke University Hospital discuss the end-of-life experiences by the patients they've cared for, what those patients think of the dying process, and the idea of a good death. Cultural, religious, ritualistic, and personal beliefs play a significant role in shaping end-of-life decisions. With an aging population and a nearly doubled life expectancy, conversations about end-of-life care are more important than ever. While life expectancy has recently declined due to the pandemic, the majority of deaths still result from chronic conditions, making many of them somewhat predictable. Although most deaths occur in acute care settings, around 20% happen in long-term care facilities and another 20% at home. In my personal experience, when my father-in-law received hospice care at home following a terminal diagnosis, our family felt that he passed with dignity. The emphasis on prolonging life and treating illnesses has made it challenging to prioritize conversations about death and dying, and how best to address the unique needs of each patient and their loved ones. Here are the different causes of deaths comparing the 1900s to recent times. This data is from the CDC 2022 Morbidity and Mortality Report. Due to the increased life expectancy, chronic diseases have factored into this data, as well as COVID-19 due to the pandemic. That data should change in a few more years. Why have a plan? Because why not? If there are decisions we can control, we should embrace the opportunity to do so and encourage others to do the same. When critical medical decisions need to be made, half of those affected are often unable to make them, defaulting to aggressive treatments they might not want. Without early conversations, it becomes challenging for families to agree on what the patient truly desires, leaving much open to interpretation and debate. Only 25% of Americans have put their medical care wishes in writing, a statistic that highlights the importance of planning. I recall being surprised when working with seniors in a continuing care retirement community to find that less than 30% had a living will or advanced directives. Most of the seniors were over 75 years old and living with chronic conditions. To address this gap, we implemented an initiative called the Blue Bag Program. We worked with interested seniors to help them complete living wills, advance directives, healthcare POA, durable power of attorney, and DNR forms if they chose to. These documents were then packaged in a blue bag, placed visibly in the refrigerator. The idea was simple. In the event of an emergency, family and friends would know that the senior had advanced directives in place with easily accessible information. We also provided the documents on flash drives for quick access during hospital visits or emergencies. The key motivator for this program was the seniors' fear that their loved ones might make decisions contrary to their wishes. Many expressed a desire to relieve their families from the burden of making difficult decisions on their behalf. I found this to be both admirable and profoundly thoughtful. This program is made possible by the protections of the Self-Determination Act of 1991, which empowers individuals to make informed decisions about their medical care, including the right to accept or refuse treatment. This legal safeguard ensures that initiatives like the Blue Bag program can thrive, giving seniors the autonomy to make their wishes known and accessible in the event of an emergency. Importantly, patients retain the ability to change their decisions at any time, as advanced healthcare directives can be updated, replaced, or edited as long as the patient has decision-making capacity. In line with this, we now ask advanced directive questions to every patient upon admission, ensuring that their medical preferences are documented and respected throughout their care. In the context of healthcare directives, nurses play a critical role in ensuring that patients' wishes are respected while adhering to legal and ethical obligations. Healthcare directives provide specific guidance regarding a patient's treatment preferences, particularly when they are unable to communicate these preferences themselves. Here are the key nursing implications for healthcare directives. Nurses must be well versed in the relevant state and federal laws governing advance directives. This includes understanding what forms of directives are legally recognized in the state of practice and ensuring that patient autonomy is respected according to these laws. Nurses must also act in accordance with ethical principles like autonomy, beneficence, non-maleficence, and justice. Upholding patient autonomy in particular is essential when a patient has made clear their wishes through directives. Nurses are responsible for documenting all discussions, decisions, and care provided based on healthcare directives. This includes noting when the directive was consulted and any actions taken in response to it. Nurses must be aware that failure to follow a healthcare directive or mistakenly providing care against a patient's directive can result in legal consequences. Ensuring that the patient's wishes are clear and followed precisely helps avoid liability and ensures ethical care. By upholding healthcare directives, nurses balance legal requirements with their ethical duty to advocate for patient-centered care. Proper education, documentation, and communication are critical in ensuring that a patient's wishes are honored in complex clinical situations. Please refer to Chapter 8 and 12 of your Cherry book for further clarification should you need it. Now, sometimes decision-making defaults to ex-spouses or estranged family members simply because they are the legal next of kin, even if they have no meaningful relationship with the patient. Ideally, these individuals would step aside when they recognize that they are not acting in the patient's best interest. Recently, I encountered a situation involving an 80-year-old man who had been estranged from his family for most of his adult life. Without any advanced directives in place, he ended up on ECMO after suffering cardiac arrest with a very poor prognosis. Although his best friend was the one who truly had his best interest at heart legally, his estranged sister was considered next of kin. Fortunately, she recognized this and relinquished her decision-making rights to the friend, who was able to make the difficult choices based on what he knew his friend would have wanted. Advanced healthcare planning is a complex process. It is important to actively engage your patients in discussions about this, or at the very least, ask them whether they have advanced directives in place. If they do not, consider asking if they are interested in completing one. This can be part of the admission process. You can refer the patient to social worker to assist in completing an advance directive form. Once it's finalized, advise your patients to discuss their wishes with their loved ones and ensure copies are distributed to their designated decision makers and primary care providers. Consider the 5 Ds as they serve a guide to reviewing and updating advanced directives due to significant life changes. The first D stands for decade. Has it been 10 years since you last updated your advanced directives? A lot can happen in 10 years, right? The second D is for death. Has a previous designee passed away? And so you must pick another one. Did you go through a divorce? Do you want to designate someone else or keep your ex-spouse as your decision maker? You are facing a terminal illness or a new diagnosis. And lastly, are you having a decline in your health? A durable power of attorney authorizes someone to handle legal and financial matters on your behalf and continues to be effective if you become incapacitated. In contrast, a durable power of attorney for healthcare specifically appoints someone to make medical decisions for you if you are unable to do so as part of an advance directive. An advance directive is a way to ensure your healthcare wishes are followed if you're unable to communicate due to illness or injury. It allows you to appoint a decision maker known as a healthcare proxy who can make medical decisions on your behalf. And it also gives you the opportunity to write down your specific healthcare preferences, such as treatments you want or do not want, ensuring your wishes are respected even when you're unable to express them. In California, there is no single required form for an advanced healthcare directive, and there are several options to choose from. You can obtain forms through hospital social services or chaplaincy departments. Additionally, you can download forms from any state via resources like Caring Connections. The website is here. Based on these wishes, the physician writes the order in line with the patient wishes. To make healthcare advance directives legally valid, it must include your signature and the date. Additionally, it requires the signatures of two witnesses or a notary, though not necessary to be notarized in California. If you are in a skilled nursing facility, it also requires the signature of a patient advocate or ombudsman. The nurse cannot be a witness. Here's an explanation of what to do with your advanced healthcare directive document. You want to give a copy to your agent, ensuring that the person you've designated as your agent has a copy and that they do not need the original, so keep that safely stored. Distribute copies to other close family members or friends who may need to be aware of your wishes. And you want to share your advanced healthcare directive with your doctor and have it included in your electronic medical record. Always have a copy handy, especially if you are going to the hospital or traveling. But when you're traveling, you want to bring a copy with you to ensure your wishes are known if needed. Remember that photocopies of your Advanced Healthcare Directive are just as legally valid as the original. When selecting a person to make healthcare decisions on your behalf, choose someone you trust who understands your values and preferences, who is willing and able to make the decisions you want. This individual does not need to be a family member. It's also wise to select an alternate decision maker in case your primary choice is unavailable. Be sure to inform others about your choices and explain why you selected that person. When planning your healthcare directives, it's important to reflect on your personal goals of care. This can include what medical treatments you specifically want or not want. Indicate your preferences for comfort, care, and pain management. Decide where you would prefer to spend your final moments. Do you want it to be at home, in the hospital, in a hospice setting? Include any specific doctors or healthcare providers you trust to manage your care. And define what quality of life means to you and how that impacts the care you wish to receive. Also provide instructions regarding organ or tissue donation after that. These considerations guide your healthcare team in respecting your wishes. A post POLST stands for Physician Orders for Life-Sustaining Treatment, is a medical order that outlines a patient's preferences for end-of-life care, including decisions about treatments like CPR, intubation, and artificial nutrition. It is designed for individuals with serious illnesses or frailty, helping ensure that healthcare providers respect their wishes during emergencies. Yes, a pulse is valid in California and is commonly used across the state. Once signed by both the patient and their legal decision maker and a healthcare provider, it becomes a legally recognized medical order that must be honored by all healthcare professionals, including emergency personnel. Your pulse should go with you everywhere. Yes, it is bright pink and it is an actual order. It is recommended for individuals with chronic progressive illnesses, those living with long-term or advancing diseases, patients facing life-threatening or severe health challenges, those who are very weak or vulnerable due to age or other medical conditions. It also applies to people of all ages with serious health issues, not just the elderly. The pulse ensures that their medical care preferences are honored during emergencies. It is important to think about our wishes for medical treatment before a health crisis. The slide shows where pulse fits into the advanced care planning continuum. It starts at age 18. But notice that what is the word along the left side spells conversation. Because it's very important to have an ongoing conversation over the years with your healthcare decision maker, family, and healthcare provider. Here is a quick way to remember the difference between a advance directive and a POLS. Both are legal documents. POLS complements your advanced healthcare directive, but it does not replace it. Encourage everyone 18 years and older to have a advanced healthcare directive. It is a legal document completed in advance that allows you to make general statements about your healthcare wishes in the future and appoint a healthcare decision maker to speak on your behalf. There is no universal advanced healthcare directive form. Though anyone can have a POLST form, it is designed for those who are seriously ill or very frail at any age. It is a medical order that documents wishes for treatment at this point in time, provides guidance to emergency medical personnel, your EMS and ER staff, usually completed in a medical setting. Can be signed by the patient's agent if the patient lacks decision-making capacity. Can also be completed by the patient's agent in consultation with the patient's physician. The pulse is not just a pink piece of paper or a checkbox form. The meaningful conversations you have with your family and doctor can help everyone know and honor your wishes. Take the time to talk with your family and your doctor about your wishes for medical care. If you were ever unable to speak for yourself, your family knows what your desires were and can follow your wishes. They are relieved of the burden of making decisions for you or questioning if they made the right decision as they know your wishes. Can a pulse be changed? Yes, you can change your pulse at any time. Talk with your doctor if you would like to change your pulse form. Your healthcare decision maker may request a change to the pulse form if you cannot speak for yourself, if there is a change in your medical condition. So they can override your wishes. So make sure you pick the right person for you. Depends on where you work, but when patients that go to surgery, they usually are reverted back to full code because most surgeons would want to ensure that they keep you alive after surgery because otherwise it counts against their morbidity and mortality if you um, were to have cardiac arrest and they couldn't save you because you have a DNR form. The bright pink pulse form stays with you at all times. Keep it in an easy to find location at home, for example, on the refrigerator or hanging on a wall by your bed or with your medications. Your family should give emergency medical services staff your pulse when they arrive. The pulse will go with you if you travel by ambulance. If you are in a hospital or a skilled nursing facility, the pulse will be kept in your medical chart. It is helpful to keep the pulse along with your advanced healthcare directive in a plastic sleeve so that it doesn't get wet or ruined. Now, just going back, here is a brief summary of the significant legal and ethical cases involving Karen Quinlan, Nancy Cruzan, and Terry Schiavo. Karen Quinlan became one of the first major right to die cases in the United States. After falling into a persistent vegetative state in 1975, her family sought to remove her from the mechanical ventilator that was keeping her alive. The case went to the New Jersey Supreme Court, which ruled in favor of her family's right to withdraw life-sustaining treatment based on her right to privacy. Karen Quinlan was weaned off the ventilator but lived in a vegetative state until her death in 1985. Nancy Cruzan's case, which reached the U.S. Supreme Court, centered on the right to remove a feeding tube from a woman in a persistent vegetative state after a car accident in 1983. Her family wanted to remove the tube, but the hospital refused without clear evidence of Nancy's wishes. In 1990, the court ruled that competent individuals have the right to refuse medical treatment, but states could require clear and convincing evidence of a person's wishes. Missouri courts eventually allowed the feeding tube to be removed after more evidence of her wishes was provided, and Nancy died shortly after in 1990. Terry Schiavo's case involved a long legal battle between her husband and her parents over whether to remove her feeding tube after she entered a persistent vegetative state in 1990. Her husband argued that Terry would not want to live in such a condition, while her parents believe she could recover. After several years of legal disputes and multiple court rulings, Terry's feeding tube was removed in 2005 and she died shortly thereafter. Her case highlighted issues surrounding advanced directives, end-of-life care, and the role of family in medical decision-making. These cases had significant implications for healthcare law, ethics, and the importance of having clear advanced directives. Now, doctors can step in and issue a medically futile order, overriding a patient's advanced directives in specific situations where the requested treatments are deemed medically futile or non-beneficial. Medical futility occurs when a treatment offers no reasonable chance of achieving a meaningful benefit for the patient, such as improving the patient's condition or prolonging life in a way that aligns with the patient's goals of care. In such cases, physicians are generally required to consult with the patient's family or decision maker. The physician will discuss the situation with the patient's family or legally appointed surrogate to explain why the treatment is considered futile and explore alternative options like palliative care or hospice. A recent case I remember being a part of involved a patient who underwent a complex aortic dissection repair and CAB times 4. The patient is a father of young children. He received extensive interventions, including over 12 units of PRBC, 6 units of platelets, FEVA, 6 units of FFP, 15 units of cryoprecipitate, and numerous medications in an attempt to stop internal bleeding. Despite these efforts, the patient remained critically ill with an open chest and on ECMO, and all interventions ultimately proved futile. The physician, recognizing the futility of continuing treatment, wrote a medically futile order after exhausting all options. The patient's wife, understandably not ready to accept the situation, pleaded for continued interventions. The doctor, showing great patience and compassion, answered all of her questions and took the time to explain the situation thoroughly. This same level of transparency and support was extended by the three nurses, yours truly, assigned to the patient's care, ensuring everyone understood the gravity of the situation and the limitations of further treatment. In closing, I want to emphasize that advanced directives and end of life care planning are vital components of patient centered care. As future nurses, you will play a key role in ensuring that your patients' voices are heard, even when they cannot speak for themselves. Engaging patients in discussions about their healthcare wishes, advocating for their preferences, and providing compassionate guidance to families during difficult times are essential parts of your role. Remember, these conversations are not just about paperwork, they are about honoring the dignity, values, and wishes of each patient. By understanding the importance of advanced directives, you are not only preparing to provide excellent care, but also fostering trust and respect in the most challenging moments of your patients' lives. Thank you for your dedication to this important work. Lastly, please do not forget you can send me questions through email or text or in class, but do let me know if you have any questions. Thank you for your attention. I hope you have a great rest of your day.